I often get a feeling like the muscle on the top or right side of my right eye is pulling or tearing. Seems to happen when I move my eye too quickly or beyond a certain range of motion. The feeling can take up to a week to feel better. It is quite uncomfortable. During this time, I can only rest my eye and stay out of bright light. This happens about once a month since my injury 2.5 years ago. Any ideas what could be causing this is this termed eye strain? There are a number of interesting symptoms that can come up when vision has been impacted after injury. With that light sensitivity and everything, I would definitely urge you to make sure that you've had an appointment with an optometrist who works in this area, because there are a number of things that need to be ruled out, such as iritis, other inflammatory conditions, and physical damage to the eye, because there's a difference between the type of injuries caused by head injury where it stops how things work together well, and then when there's actually physical damage to the anatomy of the eye itself. So the best thing I could give you there, and again, remember, none of this is medical advice that I am giving, but I would definitely make sure that you do get a thorough examination for that. The next question, and back to that too, as far as eye strain goes, eye strain is generally more of an ongoing strain feeling. It's not usually so much that sort of like sharp tearing feeling that you're describing with that. Again, which is why I would definitely urge an examination. Next question, my prescription glasses now make me symptomatic since my concussion. My optometrist won't redo my script. Is this something a neurooptometrist could do? Absolutely. So what can happen is that after you've had a concussion, if your eyes and your brain aren't working together quite as well, a prescription that you could have used well beforehand might actually start to cause you more symptoms. You may have more trouble focusing through it, or some of the depth and spatial effects of that prescription could change. So it is really, really common that people's prescriptions need to change after head injury. And unfortunately, the way that we're taught in optometry school, in most optometry schools at least, doesn't really accommodate for that. So yes, please find somebody who works as an optometrist with a special interest or specialization in neuro, or a neuro-optometrist near you. Next question. Can you have iritis if your symptoms connected to light sensitivity are, say, headache? Now, the common signs of iritis usually are pain with light, and then when the eye doctor looks in the eye, we're often going to see cells or flare or signs of inflammation with an iritis. Now, there are some sneaky sort of subclinical iritis cases where it causes a lot of the symptoms, but the doctor doesn't see the signs. Those are often still treated with the same steroid drop medication for that. The other saying, one of my wife's favorite things to say is you're entitled to have more than one problem. So, you may have iritis causing things, and you can have other problems that lead to light sensitivity too. Unfortunately, a lot of people don't understand how binocular problems with how the eyes work together can actually be a major cause of light sensitivity. What are the tips and tricks for dealing with visual attention and remembering what you've read? Also, with light sensitivity in stores, cloudy days, screens, busy places, I find I can read for a while and then eventually I stop absorbing information. Interestingly enough, that's also one of the things that I dealt with in university too. So the number one thing that you want to do is thoroughly look at how is that system working. We need to see how are the eyes and the brain actually working together, because if when someone's reading, the eyes don't track and move properly, they're going to have a lot more, they're going to burn out faster, they're going to have a harder time with attention and focus. And that was something personally that I went through. As far as for busy stores and places, again, same thing. If we don't process vision well, we're way more sensitive to places that have a lot of visual stimulus, and it's really hard on our system. So the tips and tricks, number one, make sure that you've got a prescription that's been given to you that helps how your eyes and your brain work together in those type of environments. And I'd say most people who are sensitive to those things, there is something that will benefit them. It's often small amounts of Prism, certain tints and other things, but you are going to need to see an optometrist who really works at treating these things in this area, not just sort of any optometrist. There's the obvious tips and tricks, kind of avoid it, wear hats, wear whatever, but the best things you can do is get that system working properly again. How do you know if attention and cognitive fatigue issues come from cognitive or vision issues? Well, at the end of the day, vision really happens in our brains. Our eyes are the same neurological tissue. There's not a separation the way there is with other senses. But, what you want to look at really is if you can examine how the visual processes work. If they work fine, then we know it's not going to contribute to, attention and cognitive fatigue. However, if vision doesn't work well, then we know it will contribute to it. And we can cause the same issues in someone by making them wear glasses that actually cause their vision to work very poorly or have to work much harder. So essentially a thorough examination from that standpoint, because it is hard, because a lot of people are like, oh, I get fatigued when I do cognitive things, but the majority of the cognitive things we do are heavily visual. So that's where I'd say a thorough workup on that. Another favorite little test of mine, at least just to see if discomfort or headaches come from that, is pattern glare. That's another one to do. Can you talk about any specific questions we should ask a neurooptometry office to ensure they fully understand how to work with concussion rehab? Great question. This actually goes both ways, and it can be really tricky. A lot of concussion rehab programs don't properly take vision into account. And a lot of people doing neurooptometry may not understand how to integrate with that team either. And it really comes from both sides. And what I mean by this and where we have to be careful is, say, for example, if we're working at some visual rehab activities, but there's a lot of head movement involved, etc., but somebody's neck is a primary part of the problem, we're going to interfere with our rehab. We're not going to get as far as we should, symptoms are worse, etc., because the neck will be driving a lot of issues. Same from the vestibular side. That said, from a cognitive rehab standpoint, working on activities, doing more reading, doing word finds, like trying to do sort of what often gets called quote unquote concussion rehab, if there's visual problems and vision's needed to do those activities, which most of it is, then you also have a big issue. So sometimes maybe the question might be is, hey, does your office work closely with any physios or OTs who do a lot of vestibular rehab and other pieces as well? Because I'm almost like a mechanic in a sense where I think the problem sometimes is that when we look at treating concussion and when we look at dealing with concussion, we need to look first at the areas that are impacted by concussion. So, off the top of my head, the primary stuff, cervical, vestibular, and visual, so when you work with people, it's really important that they understand the areas that they're treating that have been impacted by the concussion, rather than just kind of like we just broadly treat concussion. I think that's a mistake that's often made. So yeah, ask an office if they have people that they work closely with. Usually your other professionals will too. And like anything else, always be slightly wary of the person who kind of thinks that they have and know and can tackle everything. Again, I find that best team and the best approach through things is proper cervical care, proper vestibular and proper visual, and the people who know how to play together with that, and all the sort of other cognitive exercises, really those things get addressed once those other factors work properly. Because again, working on things around memory and attention is pointless if the vestibular system or the visual system is continuously spiking and causing issues. Next question. I was diagnosed many years before my concussions with ADHD, then adult ADHD. I also have learning disabilities such as dysgraphia and dyslexia. So many local doctors wrote off my vision issues as ADHD or prior disabilities. Could vision therapy help? The typical answer is maybe. It's going to depend on what goes there. So again, it's really important that from a visual perspective, we're not treating dyslexia, dysgraphia, or ADHD, but if you measure it and there's visual problems that are causing some of those symptoms, then we know that treating it visually will help. So I have many patients who have a long-standing history of learning disabilities such as dysgraphia and dyslexia. And a whole different side note on where vision can play into some of those things, and sometimes misdiagnoses and sometimes vision is not involved at all. But oftentimes vision therapy and the right glasses can be massively helpful for that stuff, but it all starts with a thorough exam to be able to tell. And then at least you can rule in or out. But to the writer of that question, I would say, please find somebody in your area, because those kind of cases can sometimes be some of my favorites, because sometimes their concussion ends up being, the silver lining of it is the fact that they got into a place they could get treatment for visual stuff. And the amount of people I have who can actually read and learn better than they could before they were even concussed is there's plenty. So please see someone. All right, how do you tell if the prescription is right for you? How quickly should you adjust to a new prescription? Example, I saw my neurooptometrist, then eventually switched to a regular optometrist. Neurooptometrist measured my right eye was weaker than my left. Regular optometrist measured left slightly weaker than the right. Is there a brain correlation or reason for this? So a couple of things to break down in there. As far as if a prescription's right for you, most of the time, the thing that I usually go by is within a week or 2 weeks, I mean, you should be finding net benefit from a prescription that's been given. So usually within a week to 2 weeks for my patients, you know, sometimes that first week can be slightly uncomfortable. There are some kinds of cases where I have to counsel them like, look, you know, and one of my personal friends, it was like, he's like, for 3 weeks, he's like, I wondered if you knew what you're doing. And now all of a sudden my eyes feel the best they've felt in 25 years. So sometimes it can be a little longer, but ask the doc. Now, the challenge with the measurements is measuring your prescription it's not as simple as measuring a shoe size or measuring the dimensions of a room. The prescription is going to come down to in part how the optometrist is doing the test and how you're taking the test too. So there's a lot of specific techniques and things that can be done to help ensure that your eyes don't overfocus while you're prescribing. But then also, you know, when you give a prescription, it's almost never just what you've measured. You want to take into account what you've measured, but then figure out how to prescribe in the way that actually helps their vision function the best. And it's not always what people have just said is the most clear when you are measuring that. And in fact, that can be kind of dangerous. You know, it's like if we did your diet based on what you said tasted the best, you know, we'd be in for a lot of trouble. All right, where can we find the visual test for phones? I kind of assume that somebody's talked about maybe pattern glare. If you go to our website, www.opto-mization.com, good George, just Google my name and pattern glare. We have an image on it there, or just Google it. The images are everywhere. In my last month of vision therapy, as issues were being fixed, I noticed I would see a glare whenever I was on my computer watching TV. My OT, optometrist, or vision therapist, neurooptometrist didn't know what to make of it. It is better when I wear my blue light glasses, but doesn't resolve altogether. What's causing this and what can I do about it? I mean, off the top of my head, a couple quick things I would think of. If you do notice a difference when you are wearing the blue light glasses, there are certain tints and things that your neurooptometrist could really take into account. Oftentimes stuff like that, you know, you'd be a prime candidate or a good person. See if looking at the image of pattern glare kind of really elicits that same thing. Then with your neurooptometrist, they can cycle through some different ideas around Prism and other, you know, prescription reductions or whatever to see if they can get the symptoms to decrease with that. So as a doc, the first thing I'd want to do is you know, get you into the room, see if we can replicate that same feeling, and then actually trial some different prescriptions there to see if we can bring it down too. I've been working with a neurooptometrist for about 15 months and lenses have changed 3 to 4 times. The changes are very small. What does this mean? I know the size of Prism is decreasing. Great question. So when we prescribe glasses that are based off of function, it has a lot to do with how the person's system is working at that time, and you want to give a prescription that best supports it. And that can change as you go through treatment. It can change even without treatment, but it definitely can change as you go through treatment. So really just the changes, it doesn't always necessarily mean anything particularly good or bad, depending on the case. And honestly, whether Prism increases or decreases too, never get too caught up in that to some degree. Now, there are some types of Prism that, yes, if it keeps increasing, it can be a little worrisome in some cases, but you know, have your optometrist break down which is which, because at the end of the day, almost every lens that's prescribed winds up with Prism in it the second you look off the center of the lens, or in progressives, it gets put in there by the companies without people even asking for it. So, you know, the term Prism gets, you know, it almost has this quality to it where people feel like it's maybe like a medication and you want to make sure you don't get too much of it, etc. But it isn't necessarily. But lenses are changed functionally as you go, and it should continue to help improving stuff. I'm currently doing vision therapy, going in once a week, and it takes a lot out of me. My eyes are strained for 3 to 4 days after. Plus, I feel cognitive fatigue. Do you have any tips or tricks for reducing the negative impact from the visual exercises, especially considering I have to continue this for several months? I don't think I can handle 3 days a week where I can't function. Okay, so 3 to 4 days of eye strain and a bit of cognitive fatigue. That part doesn't sound so bad, but 3 days a week where you can't function, that's bad. This has changed through the course of my practice. Earlier on, it was often much more, yes, we're just gonna have to suffer through it and whatever. But coming to a point where you don't want to be putting your system into such a spike of symptoms. So there's a couple of things. One, Parkwood point system and pacing. You know, make sure, you know, your visual rehab is going to be helping you in a bunch of areas. But if it's really kicking up symptoms for 3 to 4 days after where you can't function, I mean, chances are they're going to have to pare it back a bit. Make sure you've got the most helpful Prism glasses or tints or whatever else, binasal occlusion that can be used in your case, because it's a question of both making sure the therapy's not overdoing it, but making sure you're not overstimulated in the rest of your life too. Otherwise, it will make the therapy sessions worse. And sometimes that does mean having to pick and choose your stimulation for those things. Sometimes seeing patients who don't end up being able to cut back any work or overdo it in too many other ways, they end up really not doing well in vision therapy because they can't really tolerate any of the therapy. Not because the therapy itself is too hard, but because by the time they're in the office, they're at the tipping point anyways, and it really doesn't take much to push them over. All right, is light therapy legit, where you stare at a light to open up a field of vision? Also, if time, do you understand how growth hormone impacts ocular motor function? I am not an expert in terms of the hormonal side of stuff, but I do know there's some really cool stuff going on in that area, especially after concussion. From is the light therapy legit? If you asked me 10 years ago, I would have said not a chance. And part of that comes in terms of how it's pitched. But understanding now, I mean, we have cells in our eyes that synapse at our hypothalamus, and it's called the accessory optic tract, and it doesn't go anywhere into our normal, like what we see vision, but it massively it can impact for certain individuals, and that's where I'd say, is light therapy legit? Yes and no. Probably depends on how it's being practiced and who it's being practiced on. It's kind of one of those things where there's the gray area there. Amazingly helpful and can do so much good for people, and some people aren't as sensitive to it. And then I think you also have some practitioners who probably use it when it may not be necessary. You know, it's like so many other things. You know, it's like acupuncture legit, or even they used to say for physio, like it's physio legit. You know, my grandpa's favorite saying was, you know, oh, it'll get better with physio in 6 weeks and a month and a half on its own. And that was how it used to be viewed. Obviously, people don't think like that now. Well, some might, but kind of the same thing around the light therapy. You know, it takes the right patient, the right candidate, and the right way of using it. And even then, nothing is a panacea and going to help everything. When my PCS was really bad in the beginning, I could only wear my glasses. I could not wear contacts at all. Would there be any sort of explanation for this? My vision would feel so off even though my prescription didn't change in either. Yes, glasses and contacts are quite different. Because the contact lens is on your eye, it actually has a different effect on prescription. This can be both due to strength. You know, oftentimes if your prescription's over about a -4, the contact lens needs to be less strong than the glasses are. But at the same time, the glasses actually, like say if you have somebody who's like a -1, -2, -3, the glasses actually shrink how they perceive their environment. And a smaller, like a shrinking of your visual world does impact how your eyes and your inner ear work together. And this could be for better or for worse, because there's lots of people who have problems using their glasses after and can only wear contacts. So yes, the two are quite different. Make sure you're working with an optometrist who thoroughly understands that, or it's gonna really get in your way. I've been told I have PPPD from a functional neurologist as I deal with dizziness, lightheadedness, walking on ice like in a funhouse, feeling off balance, sensitive to motion and objects around me, sometimes moving slightly since falling and hitting the back of my head. I'm in vision therapy now after 2 years and considering vestibular physio. I'm also seeing a Nuka Chiro who unfortunately just does passive adjustments, and I don't do any neck exercises at home. Not sure what to do next, still struggling. I've been in vision therapy for 2 months and wear Prisms. Thank you. That's a lot to download. Again, the mechanic and engineer in me looks at it and goes, okay, let's break down the different areas and really target the things that are necessary for the other stuff. For example, if the neck is a big issue, you know, you're not going to progress in vestibular rehab quite the same way that you should, because so much vestibular rehab involves movement at the neck. My favorite people to see for that, to be honest, either physios who are really, really good at it, or, you know, from the chiro side, somebody really strong in ART, etc. Often makes some of the biggest differences for that. And if you want to know how much your neck really kicks into dizziness sometimes, my favorite test for that, simply keep your head straight, turn the rest of your body under your head. You're not changing your visual stimulus, you're not changing your vestibular stimulus, but you are changing the position of your head at your neck. And if that spikes any symptoms, you know, that's a big indicator in terms of your neck really being a main part of it. You know, the Nuka Chiros can be amazing, but I definitely, and even in conjunction with the Nuka, I'd see somebody who really does good ART, and talk about this with your vision therapy doc. And if you're going to mix in the vestibular physio, remember a lot of vestibular stuff needs vision as part of it, and a lot of vision needs vestibular too. So find people who understand where those things fit and how they play together. That's probably the biggest thing I've learned over the years, is you have to quarterback those things properly so it kind of goes in the right area. Otherwise, you could be doing all your vestibular physio, but it needs vision to work properly and it's not, and it just causes more symptoms and doesn't work well. But the same goes in vision or with your neck too. If you're guarding your neck because you don't like visual motion, you're gonna have a worse neck as well. It'll be treated and it'll just keep getting bad again. So try to see if you can find the people who really play together. And unfortunately, some professionals are very siloed, but hopefully you'll be able to. What specific sort of vision assessment is truly needed to get the full scope of the issues? Is this something that I can specifically ask neurooptometry? Yeah, I mean, basically the visual assessment should look at how your eyes track, focus, work together, and how your visual and vestibular systems integrate. And these don't need to be big, long, massive, this isn't like several hours of testing. Somebody who really knows what they're doing can get to the crux of it pretty quickly. So that's really what I'd ask for, is just make sure they work with concussion, and they understand how the visual and vestibular stuff work together. And again, back to what I said, not even work with concussion, but work with the vision problems that are often caused by concussion. My first 2 years now of 2 to 5 years after my concussion, my eyes have been an issue, but I could watch TV for the most part, maybe 1 to 2 hours a few days a week. After a bigger setback, it's impossible to do. This and being in stores and having conversations and so on are so much worse and still are. Is that a common thing that can get so much worse, and can say something about what might have happened? Well, I mean, here's the hard part. We're all aging all the time. And, often we often don't compensate for things quite as well as we used to. And so it is really common sometimes for that stuff to become a bigger issue over time for people, literally just from an age perspective. I mean, your prescription could have changed within that time too, and might not be being supported as much. So there's a few other things there. Again, thorough exam will be able to show that up. Have you ever heard of TMJ affecting vision? Been grinding my teeth from all the stress, and my neurooptometrist said TMJ can also bring on dizziness. Unfortunately, that's not an area I'm super expert in. In my head, I often look at it like, generally we grind when we are under stress. So then look for the things that are putting your nervous system under stress. Vision can be one, vestibular, cervical stuff too. But then there's also patterns that happen there. You're always clenching, always grinding, which is something I used to do. And then that can just be a pattern of how you do things. And then often, you need to treat it to treat that pattern. But I'd also go looking at like, where's all that, what other systems is that stress coming from in conjunction with that? Can you comment on the role of eyes in motion sensitivity and sickness? As far as eyes go, not really much to do with our eyes, but it does have to do with our vision. Think of your equilibrium as 3 important systems, apart from blood pressure and medications and whatever else, but 3 important systems. Visually, we use our vision to understand depth and space and where things are and where we are in relation to stuff. Vestibularly, that system also tells us about our position and acceleration and changes in position and space. And then proprioceptively, and that's where the cervical stuff plays into it too. So between those 3 things, now if any one of those systems is really not working well, that's where it can bring in motion sensitivity and sickness. And the goal is figuring out which system isn't working well, or it can be more than one. So that's really where that plays into it. So if you think about it, for example, if you're on a boat and the boat's moving up and down, but you're not seeing the ocean, and so visually it looks like your world's still, but your brain can feel it moving otherwise, that's where people get quite seasick. And the common thing there is, okay, get up above, look at the horizon, so that you're seeing things moving as well. And so the systems line up better. So that's really what it comes down to. They can play a role if the depth and spatial parts of visual stuff is off, because then it disrupts the equilibrium of all the other systems. I realize the answer to this will be different for everyone depending on the specifics causing the issues, but if someone has a mixed bag of visual things, snow syndrome, balance, tracking issues, the long thing, where it affects your ability to work or stand properly, but you're not able to access any sort of physician or practitioner help, having to do treatment on your own, are there any general exercises or tools that can be done at home to help yourself? I know this is different for everyone and you need to see the appropriate help, but anything in general. That is so hard, so hard. Even if you can't see someone, like you can't get there, I'd see if people can do telemedicine stuff with you, because the challenge being is like, you know, it's like giving physical exercises to someone if you don't know whether the leg's broken or just strained, or if it's a sprain or a tear. The things that you say could actually end up causing harm. So whomever wrote that in, I would encourage you so much, even if you can't get anywhere for whatever reason, if you can book yourself a telemedicine appointment, at least somebody can try to point you in the right direction there. Can dysautonomia cause the visual vestibular symptoms to be worse? My PT and neuro-opt have said many of my visual issues will settle out once we get the ANS issues improving. If one tends to be more sympathetically dominated, do you have any recommendations from a neuro-opt approach to help shift this? Yeah, from the optometry side of it, I usually look at how do we keep you from getting visually overstimulated. Make sure they're using proper, you know, if applicable, prisms, tints, different prescriptions for reading or computer, etc., binasal occlusion. Sometimes people for the light therapy or syntonics are sensitive to it, and that's also kind of where tints come in. So those things are super helpful. So that's really what I'd be looking at is, you know, from a visual side, how do we reduce it? So good question. Do you treat patients from the US? Yes, I think the farthest away I've treated someone from is Saudi Arabia. Now that said, generally my encouragement for people is really find somebody locally. Because if you can get a closer, good local relationship with stuff, these are tricky cases. It's not as simple as just, you know, here's a routine or here's a whatever. But if you can get set up with somebody locally, it's so much easier. Now that said, I mean, I do have patients who fly in to see us every couple months and we help them with treatment from afar as well. But that's generally only when they're in places where the local care either hasn't worked for them or there literally isn't anyone in that area. How do we find providers who are qualified in evaluating and diagnosing vision problems in PCS patients? There's a number of different associations, OEP, NORA, N-O-R-A, COVD, and honestly, I Google it in your area too. And you're gonna find the practitioners are different, and that's a challenge. There's different ways of approaching it, like many other professions, and you're gonna have to find the one where it really feels like it's gonna work for you. You've got a good bond, good communication, and you feel like you're understood. I've seen two neuro-optometrists. The last one I saw was a lot more helpful than the first. My eyes got stuck if trying to focus on one point for too long and sentences can start to look crooked when I read, and patterns like the test you showed us flickers like crazy. I've also seemed to be super aware of my peripheral vision and gets lots of eye-pulling sensations. I've noticed on one occasion, one of my eyes will sometimes not converge as much as the other one. They suggested a lot of my visual issues are resulting from being in fight or flight most of the time. Can fight or flight cause a lot of ongoing visual issues as these? I'd say it goes both ways. I mean, the visual issues can cause the sympathetic response of fight or flight, but yes, when you're in fight or flight, it's worse. And that's often where you'll notice that, you know, for people who have trouble being aware of periphery, if you actually get them breathing properly and grounding and out of that fight or flight, their periphery does open up more. Whereas in that stress state, it tends to really close in, but it does go sort of both ways. So make sure that from a visual sensation, they're doing the things that can bring down the visual triggers to that. You know, proper reading glasses, proper tints, proper prism binasal. Really make sure that those are being utilized. Is it normal to feel almost no improvement after 3 to 4 months after seeing neuro-optometrist 3 times during this time to adjust exercises? That's a short sentence for probably a complicated situation. When I treat patients, most people, we see them often on about a weekly basis because the exercises and activities need to be changing almost weekly. If someone's not progressing with the activity itself after a week, we've got to figure out why, you know, or do we have to change how they're doing it or find the precursors to it. By 3 to 4 months, there are cases where you don't see improvement. I still get those. And usually it means, okay, we've got to try to investigate why we're not getting improvement. The one thing that stands out to me there is, again, that same feedback. Make sure prisms, tints being used, but also, you know, are they just giving you exercises just to do on your own at home? Because oftentimes the problem there is that, you know, this isn't about exercising things. It's about how you're doing the exercise and activity and relearning it. And you often need somebody to be helping guide you through that so you actually pattern it properly rather than reinforcing poor ways of doing it. I was told I'm no longer seeing in 3D, but 2D. Can you comment on this? That's a tricky one to comment on with that little info. Yeah, I mean, really nobody sees completely in 2D. There's cues to depth, even when you're not getting proper depth perception. So I definitely ask whoever you're seeing to expand on that a little further, and somebody who's knowledgeable in this area can. I mean, it's very common to have reduced depth perception, or your eyes don't work together well enough to see what, you know, an optometry would call like true 3D or high-level stereopsis. But yeah, don't worry. I don't think it's like you're running through a two-dimensional video game. Can a neurooptometrist treat light sensitivity issues that are experienced when strobe light effects happens? This one's super common, and I don't want to say yes always, but so much of the time there's things that we can do that bring that down, because I guarantee you, whoever's having the sensitivity of strobe lighting between trees and shady spots will also struggle in Costco's busy stores, etc. as well. When I tried going back to work after my brain injury, my eyes began making wax while on my laptop, so I went to the optometrist. They gave me glasses. They said one of my eyes was shaped oblong, so that's astigmatism. They always found I saw better without the glasses, except when it's something far. Yeah, also if my eyes itch, I rub them, they literally swell up. They said maybe there was part of a viral infection from before. Can I shed some light? So the only thing I want to cover in that one really right now is, you know, so it sounds like they gave you glasses for astigmatism for far away. That is not the prescription you should be using on your computer or laptop. If that person doesn't understand that they need to give you a different prescription for working on your computer and laptop than what they give you for far away, you really need to find a new professional. That'd be my biggest comment there, because the amount of strain that'll come up from using that distance prescription is very, very real. Do you know what can cause issues in dim light or darkness? I don't struggle with light sensitivity, but as soon as it starts getting dark, my brain feels like my brain starts shutting down. Dim light and darkness make it harder for the eyes to work together. And we commonly see that in testing. If you dim or darken the room, the two eyes can struggle in some people to work more together. So definitely get that assessed. That's usually what it is. Why might my eye specialist suggest placing partial covering of my glasses nearest my nose, with blue on the one eye and red on the other? Is this binasal occlusion with two different colored lenses, and why? I'm not sure their exact reasoning. Personally, I mean, we're all always growing and changing professionally, and the coolest part is doctors are figuring different things out and what works for this person and that person. That is a type of using binasal occlusion, but it sounds they're also working some tints, you know, and or sort of symptomatic type approaches into that, which is really cool. And I kind of look at it like, does it work? And you should usually be able to tell, because one of the best ways to see if binasal occlusion is going to work for someone is have them look at a target, shake their head, put the binasal on, shake their head again. If it brings down symptoms, then we know that it's going to be helpful, because in some people it exacerbates it. So I'm wanting to understand what treatment might look like. Is it always prescribing glasses? Is it eye exercises or other things? It depends on the problem. Generally, for most people post-concussion, there's a combination. There's the proper prescriptions that help to support the system and improve things, improve capacity, reduce symptoms, and help allow them to get better too. And oftentimes there's also vision therapy. The eyes don't need to be exercised. The muscles are fine. But using visual exercises as ways to create feedback so the brain can better learn how to control and process the vision. What exactly causes visual problems for people after concussion? This is one that there's a number of things that get talked about. The problem is a lot of the time it doesn't show up on an MRI. And again, eyes are fine, things look intact. They are being able to see some things on functional MRIs. And the going sort of hypothesis on that is, I mean, when your head does this and different layers of your brain move at different speeds and accelerations and change, it creates shear forces between the layers, which disrupts the axonal connections. Think about it like, you know, if you had an Excel spreadsheet you'd worked really hard on, and then somebody scrambled all the formulas in certain places, and that's kind of what it ends up like. How do you know if you had issues earlier but didn't show up prior to head injury? Usually thorough history. I mean, I see lots of patients where after head injury things have gotten worse, but we talk about their past and like, you know, like, oh yeah, I was terrible at baseball, or I had trouble reading in school, or blah, 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 and things that may have indicated some visual stuff beforehand. Because you could be walking around with a visual system that kind of underperforms, but it's just made way worse after head injury. All right, I get eye floaters that seem to come and go for every few weeks since my injury. I was checked by my optometrist. She isn't worried about it. Is this normal? I guess that's hard. At least you've been checked, so you want to make sure that there's nothing sinister there. That said, sometimes you can actually be a lot more sensitive to it after injury too, so that could be part of it. Should Prisms change? I have 5 weeks of vision therapy left and my Prisms have not changed. Not in every condition. It just totally matters on what's going to help the person most through that. I'd say more often than not, for me, most of my patients, lenses and things change as we go through it. There's not always Prism in all of them. It just depends on what tools I need for that person and that task. But yeah, there are some where it literally doesn't change and it can stay quite stable too. And that's what's best for them. Just after my concussion, I have an odd visual symptom. When I turn my head, snapshots of my vision would follow me slowly. I'm dating myself here, but it was exactly the effect that was used on the $6 Million Man TV show to show when he was bionic. It went way over time, but it still comes back for short periods of time. Do you have an explanation? That's actually a really cool one. So when you're turning your head, there's a couple of different things that need to happen. One, if you're turning and looking at a stationary target, your eyes have to stay on that. But oftentimes when you're turning your head, we've got motion moving across our visual field, but then your eyes are also making small saccades and jumps to come over to where you want them to be. Now, it's common that we end up having trouble, because normally what happens is when you move your eyes, your brain actually suppresses the information while your eyes moving, which is why it doesn't look like the whole world moves. If you move your eyes from looking at something on your left to your right, you see there, but while your eyes are moving, your brain kind of suppresses the information and fills it in. So you think you're still seeing it, but you're not actually really seeing the movement. Now, sometimes when vision stops working quite as well as it should, you can actually start to get some of those experiences of seeing that movement when we go through it. Another place a lot of patients notice that is, they'll be tracking my finger, watching it moving around, and then we switch their prescription, and they say, it's like, wow, all of a sudden that went from sort of like stuttering with tracers or trailers to like, I can smoothly watch and follow that thing. Similar kind of effect to that. Definitely a cool thing. Get yourself checked out for that, because if you're in the hands of somebody who really knows what they're doing, you could actually stand to benefit a lot, because I know you see it in that place only once in a while, but that does indicate that there's probably a bunch of other areas where your vision may be part of it, but you might not realize. I have people where they talk about multitasking being really difficult, or even conversations, but they don't realize that when you're having a conversation and you're looking right at someone, it's a lot visually to maintain focus, maintain both eyes there, processing the background. Your brain has to make sense of the doubling in the background too. So sometimes people will have things that trigger them that they don't even realize vision can play a role in. So the key parts, I think the takeaways from most of the questions that were asked is one, make sure you're in the hands of a knowledgeable optometrist or neurooptometrist who practices in that area, who can really dig in and look at how these visual systems are working or not working. And make sure you're working with somebody who understands where the neck and vestibular system play into it too. Because equally as dangerous as working with somebody for your neck or your vestibular system or your concussion rehab who doesn't understand where the other areas fit into things too. Because then often you can end up being treated for way too long with not enough effectivity because some critical parts are missing. It's like continuously redoing a math problem when one of the first formulas was wrong. So find somebody in all of those areas, be it from the OT or physio, but make sure cervical stuff is getting addressed properly. Again, my favorites, either really good physios with training in the area of that, or the kind of evidence-based chiro ART model approach to it. The other ones can be super helpful too, but from what I've seen for some of the neck stuff, that's a core component to it, is that ART piece. Then, into it from the visual side, and then somebody from the vestibular side too, who again understands the interplay between these. Because, I've got physios who I work with who will send patients to me, and, I know that patient needs vision therapy, but they might not be best to have it yet at that moment. And I may just prescribe lenses and glasses that help the vestibular part of the therapy go way better. But the physio then knows that, or the OT then knows that, or chiro, that they know that they've got to be careful of what they're doing in the vestibular rehab that might involve vision. And once they can target and work at some of the vestibular stuff more, then all of a sudden we can treat the visual areas way more effectively, and then they can come back to some of the higher level vestibular stuff. And it's really, really important to have people who understand those things. If any of you are working, doing reading exercises or cognitive memory exercises or something like that, and nobody's check to see if your vision actually works properly, I mean, that's one of the first things you need to do, because you need properly working vision to be able to do those things in the first place. And yeah, like anything else, you know, always check in how long until we think if things, you know if things are getting better and on the right track, and if they're not, what do we do about it? Always good questions for your practitioners. So anyways, to the Concussion Compass group, thank you for having me on. I hope the follow-ups to these questions have been helpful for you guys. And for all of you and your post-concussion journeys, I wish you the best. I hope that you find yourselves in the hands of very, very knowledgeable and caring people, because very often, if you can get those core areas dealt with, you will start to see some meaningful improvement.